Good afternoon, ladies and gentlemen. This is Steve Love, as you know, President and CEO of the Dallas-Fort Worth Hospital Council. We're delighted that we are bringing you another great educational webinar today. And as you know, we're pleased with our associate members that bring so much expertise to the table. Today, it's going to be hosted in coordination with Para Healthcare Analytics. And Para Healthcare Analytics, as I indicated, is an associate member. They offer a wide range of revenue cycle management solutions. They have a team of experts that work in reimbursement, pricing, coding, and contract management services encompassing all aspects of the healthcare revenue cycle. And I can tell you today's topic is very important. Price transparency, strategies in a healthcare market, managed care remittance, strategies to ensure appropriate hospital reimbursement. And we've got two great experts, speakers, to discuss the pricing and the revenue stream, the reimbursement validation tools, any pricing concerns, reimbursement accuracy, and any other topic, candidly, that you'd want to bring up. I was speaking with Peter and Randy before we began, and I know they're going to focus today on specific topics, but I'm confident if you have any questions related to revenue cycle, even if it's not quite in line with what their presentation is today, I'm sure that they would be delighted to answer that question. And it's my privilege to introduce our first speaker today, and that's Mr. Peter Ripper. Peter is the president and the founder of Para Healthcare Analytics, and followed by Peter, and he'll do more of a handoff and introduction to her, but we have Randy Brantner, who's the director of financial analytics at Para Healthcare. So we're all looking forward to their presentation. And so it's my pleasure now to turn this over to Peter. So Peter, thank you for being here.
All right, very good. Thank you, Steve. Great introduction. Good afternoon to the audience. I'm on the West Coast, so it's still morning for me, but afternoon for you all. What I wanted, my section of the presentation today is a review of some of the work that we've been doing when it comes to negotiating managed care contracts, modeling changes in managed care reimbursement, looking at how hospitals are currently being reimbursed under their managed care plans, looking at issues where the hospitals are not being paid correctly, or there is hospital process issues that reduce the expected reimbursement within a managed care plan. One of the goals and the objectives of my section of today in this discussion is to give kind of a review of the process, the details, the tools, the interaction of data that we utilize with our clients in understanding managed care reimbursement, where the breakpoints are in the hospital revenue cycle, how to identify those breakpoints, how to improve that process, manage and track that process, and constantly evolve, evaluate, and refine your revenue cycle. Steve already spoke a little bit about our company. PAR has been around for almost 34 years now. We specialize pricing, coding, reimbursement, and compliance. That's all we do. So it's a very focused process we do. The issues that I'd like to speak to today when it comes to managed care contracting, number one is that I don't want you to shoot too low when it comes to negotiating your managed care contracts. We're going to talk about how we should measure your managed care reimbursement as a multiple of Medicare. Want to discuss some of the emerging trends we're seeing in managed care contracts, and I think that you may have been impacted by some of these trends, so I want to speak to those issues. Payment reconciliation and the pro formas and the contracting obstacles that hospitals are facing in terms of their limitations in their data systems or in their financial models. I'd like to review those with you. We'll go into your Chargemaster pricing, billing, charge capture concerns as it relates to managed care contracts. And then in the end, we're going to look at your payment reconciliations against your current contracts, your reductions in your allowed, and looking at denial management when it comes to your current process flow under your contracts. Okay, moving into cost coverage. One of the issues that we are constantly trying to educate and talk to our clients about is that when you're looking at contracting under an HMO PPO contract, that is going to be one of the areas that you're going to receive the highest margin reimbursement. We want to make sure that we're receiving at least that multiple of Medicare costs that we need to achieve our financial goals. Now I know that Medicare costing is a kind of a broad-based process. It is, however, one of the areas that it allows us to quickly determine what Medicare would have paid on a particular claim or in a particular contract. It allows us to measure that contract against the Medicare reimbursement, and then it allows us to estimate what our projected allowed would be under a contract or what it actually is under a contract, and to plug those into our financial models to be sure that we're achieving the necessary multiples to offset our losses against your indigent, your Medicaid, your Medicare, your self-pay. And then obviously with your commercial non-contracted, we've got the whole issue of high deductible coinsurance type reimbursement not being paid correctly. One of the things we always want to look at, though, is what is this paying as a multiple of Medicare? How can I measure my contract return, and how can I measure my go forward under a proposal to be sure that I'm meeting my financial goals? So the area that we really want to focus on this is Medicare, looking at Medicare as a function of full costs. We know that Medicare doesn't pay us full costs. We know that it published in the Federal Register, every update to the inpatient final rule, we're seeing 89%, 90% of full costs being reimbursed by Medicare. So again, we want to be able to take a multiple of that and measure our managed care proposal and actuals against that. Moving on, emerging trends we see in managed care contracts right now. The number one issue we see, and I'm talking about Anthem Blue Cross right now, but we're seeing it coming out of the Big Five. Obviously the Big Five: Anthem, Cigna, Humana, United. I missed one, I forget exactly, but the Big Five are moving more toward a fixed-based, risk-based, PPS-type-based reimbursement system. Anthem Blue Cross, in some areas they call it COPPS on their outpatient side. They may call it MOPPS. The issues that we're finding with our hospital clients is that their data systems, their contract systems, don't have the algorithms in place to be able to settle a Medicare outpatient-based claim. The packaging rules based on the status indicators, the interaction of the line items on the claims, looking at an Epic, a Cerner, a Meditech, an Athena type models, we're not seeing the ability for them to be able to settle an outpatient-based Medicare claim. Medicaid, most Medicaid plans now are APR DRGs and enhanced APG payment reimbursement on the outpatient side. APR DRG is obviously a different grouper, slightly different grouper. You've got the different levels within each DRG based upon the complexity. The EAPG methodology published by Navigant is very similar to the Medicare OPPS, but the reimbursement methodology and the values are slightly different than what we see under OPPS. We're also seeing under Medicaid that there are requirements now coming through on certain states where there's sequencing of codes in a certain order on the outpatient claim. And if you do not have those codes in a certain order and that full complement of codes on an outpatient claim, you will not be paid correctly. This is something we're seeing especially on EAPGs when it comes to observation patients on the outpatient side. On the inpatient side with managed care, we're seeing a number of contracts coming through that are based on Medicare DRGs, and we're relatively familiar with MSDRGs. We're relatively familiar on how to group an MSDRG. It's a little more difficult to value a Medicare DRG correctly using, say, the inpatient pricer routine, but it can be done. The difficult side with Medicare DRGs as a contract is with your cost outliers, and the cost outlier reimbursement and calculating that cost outlier reimbursement is a little more difficult than just valuing a Medicare MSDRG. And so as a result, we've been working with hospitals to put an algorithm out there that will pay their Medicare MSDRGs and then pay their cost outliers in the same way as Medicare would, and then obviously taking that managed care contract with a multiple of that Medicare reimbursement. Critical access facilities, I was speaking with Steve prior to coming on today. He said that 4 of your hospitals in the group are critical access. We are actually seeing the big 5 moving to some type of and requesting some type of a PPS type based agreement, whether it's multiple of Medicares or it's a per diem or it's some type of at-risk based agreement fee schedule. But the payers are trying to get away from those percent of charge agreements and move even critical access hospitals into some type of risk-based program. And it's difficult for the critical access hospitals. You've got a small population of patients. You've got a high variation in your correlation of your payments into your population base, and making those projections out and making sure that you are protected when it comes to an outlier can be very difficult for critical access. Lesser of charge limits. I think that everyone who's worked in managed care contracting is aware of lesser of charge, either at the line level or the claim level. I'm going to speak about this a little bit later. So you have lesser of charge limits, which impact your managed care reimbursement. They impact your allowed. They can be a significant impact in your overall reimbursement. The other issue when it comes to charges is the adjustment of your charges as it relates to the contract and your annual price increases within the Chargemaster, neutralizing those increases in your Chargemaster and reducing those payments that are based on a percent of charge, washing out those increases or washing them out of some claim cap limit on the contract. That's a difficult issue there. The last thing is the diversion of the big 5 to the independent testing facilities. So we have seen obviously a contraction in the volumes on the outpatient side with the big 5. They're directing their patients over to independent testing facilities. We actually have a number of projects going on right now, probably 4 or 5 projects in which we are evaluating for our clients whether to move into an ASC, whether to move into an independent testing facility, what volumes we will cannibalize out of the hospital outpatient side, and what volumes we project to increase by coming to a smaller reimbursement basis, but hopefully picking up additional volume that we have already lost over on the outpatient side. So the concept of having a separate ASC, a separate independent testing facility, obviously, or a tiered pricing or tiered reimbursement when it comes to your managed care, that's obviously a major impact when it comes to these issues. Payment reconciliation and contracting obstacles. I think we're probably all familiar with the 835, 837 data files, 835 remittance files, 837 claim files. In a number of cases, the 835 remittance file that we receive back from the payer will not have a full, robust set of data points that we may need to value and manage a new proposed contract. So in that situation, what we have to do is we have to map in 837 claim files, reconcile them to 835 remittance files, make sure that we have a good contract model in place using 835, 837s, and then using the 837 claim files to model a proposed contract. Another thing that we're seeing from our friends in the managed care payers is that they will only give us those data points that they use to value and pay the current agreement. One of our clients in Southern California has a relationship where they get reimbursed $225 for an emergency visit. And what this payer is doing, if a patient comes into the ED and then goes into outpatient surgery, or comes into the ED and say moves to the cath lab or interventional radiology, they're not giving us on the 835 that full complement of codes and charges that we're seeing. All we see is that single line on the 450, the ED visit, the $225 payment, and they conveniently drop off the cath, the interventional radiology, or the outpatient surgery side, or the observation side of that claim. So again, it's important to be able to bring 837s, map them to 835, even in your current ongoing contracts. Make sure you see the full complement and picture of the patient's services, and use that to challenge the short pays that you're seeing coming out of these contracts. Contracts based on Medicare OPPS, inpatient, PPS, MSDRGs, cost hours. I spoke about this, all patient, DRGs, and enhanced ambulatory payment groups. Sometimes they're difficult for hospitals to reconcile and model because they just don't have the tools in place to be able to do that. And so, again, you have to reach out to a vendor and be sure that your vendor can support you in that. Okay, Chargemaster pricing issues. Lesser of charge language, I spoke about that a little bit earlier, and is probably the greatest limiter we're seeing when it comes to managed care reimbursement. And I've got an example on the next slide I want to share with you. Split billing of clinic visits. Hospitals going out, picking up a physician office, making that a facility-based visit, split billing it on a 1500 in UB. The Big Five commonly now will not allow that. Their hospitals are required to bill clinic visits over on the 1500. I'm relatively familiar with several of your payers in the Dallas area. They will come in, they'll reimburse you based on a regional professional fee schedule, on a global regional professional fee schedule, and then the hospital has to take that payment and split it off between the hospital and the professional for that, for the reimbursement. So that, obviously is a vast reduction of reimbursement between being able to bill at hospital UB and professional 1500. The coverage manual, the billing manual, it seems like it's now kind of an attachment to our current agreements. The payers modify the billing manual kind of on an ongoing basis, non-covering certain procedures or requiring the consent or the pre-certification of certain procedures. And this billing manual update process is something that is done without the consent and sometimes without even the knowledge of the hospital. And you don't realize what's happening until you're looking at your remittances and trying to understand why, what you've received or what has been allowed under your current contract is not what you've expected to receive under the current contract. So the issue of the billing manual adjustments, I've seen recent language where the payers will say that they will incorporate Medicare local coverage, national coverage, CCIs, medically unlikely edits into their processing. This is all kind of additional edits that we haven't seen before from the commercial payers, and we're now starting to see them embrace Medicare kind of online claim edit type edits to adjust down the allowed charges. Okay, this next slide is an actual case that we have prepared. And to scope this for you, this is a group of 3 hospitals in the Southeast. We're looking at about 4,200 inpatient accounts and about 70,000 outpatient accounts. And this is a Blue Cross model. You can see that our outpatient reimbursement is actually pretty good. We're valuing the Medicare reimbursement at $36 million on this particular model against almost $37 million of 837 contracted reimbursement. Now, obviously, the hospital is not going to receive that full $136 million because of disallowances against the allowed. But still, it's a relatively good relationship between Medicare reimbursement to total reimbursement. But what's important to look at too is the difference between the 136 and the 125 million, a reduction of $11 million based on the lower of charges or reimbursement. So this hospital lost $11 million potentially due to that clause in their reimbursement model. On the outpatient side, we can see we're at $38 million. Again, we're looking at about 70,000 Blue Cross accounts, $38 million of Medicare outpatient reimbursement against 81 million. So we have a lower multiple, about a 2x multiple of Medicare to projected reimbursement. But again, we're looking at a $5 million reduction of reimbursement based on a lesser of. What happened in this case is that the hospital came to us with a price setting model that they had utilized with some other company and said, we have a projected CDM for 2018, we have a projected 2019, a projected 2020 CDM, and we want to know how is this going to impact us over those years. So we went through, repriced every claim, resettled this 75,000 claims, and we can see that they worked their way from about a $16 million loss of reimbursement down to about a $12 million, $12.5 million loss of reimbursement. But $12.5 million loss of reimbursement over a 3-year period, that's a significant piece of reimbursement, and this is only one of the big 5 payers. So managed care, the lesser of language, I don't know, I can't emphasize it more. It is probably one of the biggest limiter what we see in reimbursement there. Payment reconciliation, we've kind of talked a little bit about this. 835s, they're thin. They don't have all the data points. We've got to bring in those 837s to give us a robust data set to look at. We've got to be able to bring that in, model the expected reimbursement. So we need those tools to model the expected reimbursement. We need to be able to identify expected versus actual. Where are those reductions? Where are what codes are there that are causing us to lose money between our expected reimbursement and our actual reimbursement? Let's look at the trends that we're seeing in this area. Let's find out what the reasons are behind this, and let's put processes in place to correct it or reduce it or to understand why these issues are occurring. Obviously, the biggest process is to identify underpaid claims, correct those claims, provide medical record documentation, retroactive pre-cert, and then be sure that we can re-adjudicate the claim for payment. We have developed working with one of our corporate clients, Quorum Health Resources, developing trend models when it comes to denial management. And this is actual numbers from a relatively small hospital, under 100-bed hospital. And you can see that month to month, there are significant reductions in reimbursement based on different types of disallowances against the contract. So by identifying these issues, working through the process, understanding them, trending them, feeding them back, we're able to assist in working our way out of some of these issues. But the biggest problem we're seeing is registration, authorizations, coverage, patients hitting their max for the year, different types of processes that we've got to work on the front end side and make sure that we understand, where we're losing the money and what can we do to achieve it and return it. One of the issues that Quorum has come to us about is, yeah, we like all the data points and we see all these trends, but what we need to do is our staff needs to visualize the data. We need to be able to look at these numbers over a period of time, understand the data, visualize it, and then drill down into the detail. So we've developed some tools for our hospital clients to be able to drill down through the numbers, visualize what we call their yield or different statistical values, understand how they change over the 6-month period, and allow them to focus in and understand these types of issues. Visualizing data is critical because we're buried in data, and we've got to be able to bring it up to a high level, present it to management, and to embrace, get them to embrace the tools and the processes we need. As part of our program, we're offering a remit assessment off of our system. So we've got some information on that. What time is it? Let me see what time. I'm running out of time. I know that we've got a few minutes for a question and answer, and then I'm going to turn it over to Randy Bratner, our Director of Financial Analysis. Chris?
Yeah, we're checking for questions now.
Oh, okay, I got you now. Okay, I wasn't sure. All right, thank you.
Does anyone have questions for Peter? I know that Chris is monitoring them as you write them. That was a good job, Peter. You covered a lot in a short period of time, but it's very meaningful information.
I hope so. I hope so. All right. Yeah, obviously, there's a lot more detail behind all this, and anyone who wants to go one-on-one with us, don't hesitate to call upon us, and we can go from there. Okay, so what I will do, I guess no questions. What I will do is I'm going to turn this over to Randy Bratner. Randy's been with PARA now for 6 or 7 years, I think. She heads our division of financial analytics. Randy has vast experience in price setting, in models, working in hospitals, in reimbursement. So she is our go-to expert when it comes to pricing and financial analysis. So I'm going to turn this to Randy right now.
All right, thank you so much. Good afternoon. Like Peter said, my name is Randy Brantner, and I'm the Director of Financial Analytics for PARA Healthcare Analytics. Now, the slide on your screen is what was published as part of the registration information for the presentation. Now, I'm not going to read over the whole thing again, but I just want to point out that during the presentation, we'll define the hospital revenue stream pricing areas and concerns. We'll talk about identifying recommended pricing strategies, designing a pricing methodology based on cost, reimbursement, and/or pricing, peer pricing data. And then finally, we'll talk about 3 strategies for maintaining pricing transparency in your organization. Now, some of these concepts covered in the presentation might be common knowledge for some and not for others. However, I think they're all important in understanding, implementing, and maintaining a transparent pricing process. There we go. So hospital charges represent the statistical basis of cost for hospitals. And although all hospitals are reimbursed differently according to OPPS or critical access status, and obviously other third-party contracts, we still see charges represented within these basic revenue streams. Our revenue streams include observation and room rate charges, emergency room and clinic charges such as chemotherapy, wound care, and hospital clinical services. Diagnostic and therapeutic services, common in areas like radiology, laboratory, and rehab. We also see technical anesthesia, which is the hospital component of anesthesia services. Operating room, again, the hospital component of the operating room charges. Recovery and PACU. Pharmacy products, so this doesn't include the nursing administration, just the pharmacy, the drug itself. Medical supplies, again, product only, and then professional fees. So let's get started by digging into observation and room rates. Daily hospital services such as observation and room rates use revenue code 0110 to 0219, and then the observation revenue code is 0762. Now, these charges are used to represent all routine nursing and facility resources. Because of this, reimbursement and room rates is generally incorporated into DRG reimbursement and should be priced according to geographical peer group data. Otherwise, if you'd like to dig into details, a study of capital, supply, staffing, and other resources could also be performed to determine the patient price. So although it requires significant work, performing a capital study would help to ensure the pricing is appropriate according to resource utilization. However, a lot of times hospitals do not see inpatient room rate charges as much of an issue with regard to patient satisfaction. This is because insurance payers will generally collect the same deductible, coinsurance, and copayment from the patient, regardless of how much the hospital room rate charges are. Hourly observation reimbursement differs by payer, such as case rates, percent of charge, or fee schedules. These hourly charges should be priced at 1/24th of the daily room rate charge, although some facilities will use a front-loaded first hour and a lower 2 to 24-hour charge. Again, the total for 24 hours of observation care should equal 1 daily room charge. So the next slide is about emergency room and clinic visits. Emergency room visits are reported under 9928X and 99291 through 99292. There's a lot of nines there. Meanwhile, outpatient clinic codes are reported under G0463. Now, these were previously reported under those 9920, 9921 series, but Medicare recently updated that, I want to say, probably 4 or 5 years ago now. But the newer code, the G code, does present some challenges when reviewing pricing data and setting prices. So generally, we recommend pricing clinic levels as a multiple of reimbursement or at the peer group average. However, with this new code, all of the severity levels are combined under the one code. Therefore, reimbursement will be the same regardless of patient acuity, unless a third-party payer still accepts those individualized levels. So again, we recommend pricing at either a multiple of Medicare reimbursement or the average of the peer group adjusted for acuity. For example, if we set the price of the mid-level visit at a multiple of reimbursement for G0463, and then price the lower and higher acuity patients at a percent above and below that mid-level rate, that usually gives us a pretty good results when it comes to pricing. As for emergency room visits, pricing at a multiple of Medicare reimbursement or the average of the peer group is recommended. Diagnostic and therapeutic procedures. Now, these procedures are assigned specific CPT and HCPCS codes, and reimbursement will vary by payer, again, by case rate, fee schedule, or percent of charge. As a rule, we recommend pricing at either a multiple of Medicare reimbursement or the average of the peer group pricing data. The exception to this rule includes items that commonly have issues with patient satisfaction, so your outpatient laboratory and radiology procedures, for example. These items should be identified and priced competitively against other data sources, such as freestanding laboratory and radiology centers. As an example, as Peter alluded to earlier, many of our clients will select top 20 or even their whole Chargemaster of laboratory tests or radiology tests and create a separate outpatient pricing tier, which targets those prices commonly seen in laboratories such as LabCorp or Quest, whatever might be in your area. So technical anesthesia. This represents the hospital component of anesthesia administered during a surgical case. Managed care contracts generally do not allow reporting both itemized anesthesia and the time-based charge. Therefore, we recommend creating charges based on anesthesia time where applicable. Time-based anesthesia charges are based on the start and stop times recorded in the patient record. And we recommend that prices reflect resource utilization according to the 6 types of anesthesia listed here. Now, general anesthesia, MAC, and moderate sedation should be time-based. Meanwhile, epidurals, locals, and blocks are one-time charges. Because reimbursement for technical anesthesia is included in the overall surgical reimbursement, we do not have the capability to price at a multiple reimbursement or peer average. Therefore, we recommend pricing reflect resource utilization in time-based increments. Moving right along to operating room charges. Now, these are the hospital component of OR services, which include the setup, staffing, and rental special equipment used in an OR procedure. Charges are recommended to be acuity and time-based according to staffing costs and additional equipment charges. Time charges, again, are determined according to start-stop time on the surgical record. The use of special or rental equipment should be captured by bumping the procedure to a higher level. Charges are generally set with a front-loaded initial time frame, such as 30 minutes, and then additional 15-minute increments thereafter. This acuity leveling method allows facilities to account for the use of resources for a normal procedure. Meanwhile, the use of additional time increments allows the facility to also capture more complex cases and resource utilization. Again, because reimbursement for operating levels, the revenue code 0360, 361, is included in the overall surgical reimbursement, we don't have the capability to price at a multiple of reimbursement or peer average. Therefore, we recommend pricing reflect resource utilization in time-based increments. PACU and recovery charges are generally time-based with some instances of acuity or nurse-patient ratio considerations. General anesthesia usually requires at least 1 hour of one-on-one care. Once the patient is attended to for the minimum period and the nursing assessment determines the patient can move to a lower staffing ratio, the nurse can attend to 2 patients. Now, pediatric patients will usually require one-on-one care for the entire recovery period. Many facilities will create a 1-hour front-loaded charge with additional 15-minute increments. However, it is also appropriate to charge by the minute. Reimbursement for PACU and recovery is included in the overall surgical reimbursement, so we don't have any capability, again, to price at a multiple of reimbursement or a peer average. So we recommend pricing according to nursing facility resource and utilization. Pharmacy. All right. Drugs dispensed in a hospital setting can be a sensitive area for patients, as we all know, and this is due to the patient's ability to compare prices against what they pay for their drugs at a local retail pharmacy. When a patient can compare prescriptions they pay $10 a month for to a $4 tablet charged by the hospital does get some complaints on that. Therefore, the recommended practice is to create a cost-based markup with fixed add-on and minimum charges to compensate for departmental resources involved in storing, handling, and preparing the items. Also, a separate markup for self-administered drugs is recommended. Now, the concept of self-administered drugs is challenging and creates some compliance concerns for hospitals. This is because, as Peter was discussing, I think before the call, Medicare does not allow hospitals to bill Medicare for drugs that are self-administered, as these are the responsibility of a patient. Now, the definition of self-administered drugs can get a little sticky. So self-administered drugs are defined by Medicare as drugs that are administered by the patient 50% of the time in its overall use in all settings. So that gets a little tricky. Even though a patient may not actually administer the topical medication to himself during the stay, since it could be administered by him most of the time in all settings, it is considered self-administered. So for self-administered drugs, we recommend assigning low multipliers fixed down at minimum charges to those charge categories with self-administered drugs. This lessens the impact of patient responsibility or hospital write-offs, depending on the hospital's process. All right, like pharmacy, medical supplies are priced according to a cost markup. Items with lower cost are assigned higher multipliers, and higher cost items are assigned lower multipliers. Many facilities fall away from maintaining the relationship between cost and patient price due to cumbersome update processes. For example, the facility will use an established markup to determine the initial price, but in the years to follow, they'll apply an overall % increase year after year. So as the years go on, items that were set up 10 years ago will be drastically different than similar items that were set up maybe 2 years ago. Now, because of this, we're seeing the industry move towards standardization of supplies to reestablish the relationship between cost and patient price across all supplies, which in turn corrects any potential compliance concerns associated with inconsistent charging processes. Many facilities will actually employ the use of a cost threshold for low-cost items. The cost threshold varies according to facilities, but it can range anywhere from $5 to $25 is what we've seen. Setting a minimum cost threshold for what are considered billable items reduces the effort of nursing and materials management staff from having to quote-unquote chase down the charge. So that's why we see this minimum threshold varying as much as we do. Hospitals have determined that items with cost less than $5 and all the way up to $25 are not worth the time and resources of getting the charge on the patient claim. Now, each hospital's perception of this concept will differ, but there's really no right or wrong way here. We recommend reviewing the Chargemaster for what would be considered non-billable supplies. And we also recommend the use of fixed add-on and minimum charges to compensate for any department resources for handling the supplies. Finally, the separate and distinct markup for implantable revenue codes. So that would be your 0275, 0276, and 0278, your lenses, pacemakers, and implants. Many facilities will have payer contract terms that are sensitive to these items. So by simplifying the markup for these items, the carve-out language and payer contract requirements can be simplified for that area. So the chart on this slide demonstrates how the use of markups can assign lower markup to higher cost items and higher markup to items with low cost. This is how it looks graphically when we compare cost to patient charge. Now, as you can see, there's a gap there around $1,000. Now, what's happening here is the facility has a multiplier of 4 on items that cost between $500 and $1,000, or $999. Which means an item that costs $999 is being charged $4,000. However, if something costs $1,000 and a penny, it's only being charged a multiple of 3, which makes the patient charge $3,000. In essence, we're now charging less for items that cost more. So although this compressed markup is an industry standard, we need to use caution when implementing it to ensure that we don't run into issues like we see here. By incorporating the use of fixed add-ons or minimum charges, we ensure that we're charging more for the items that cost more. Finally, we have professional fees. Now, each hospital will handle professional fees differently, as Peter said, between the 1500 and UB04 billing, or not at all. They may contract that out. And it all depends on how the organization is structured. Now, professional fees are represented by using revenue codes 096X through 098X. And the 3 components included in the professional fee schedule are the practice expense, malpractice expense, and work expense. In the grid here, you can see how those relative value units, RVUs, line up for a mid-level visit code. If the facility is billing a non-facility place of service, professional reimbursement will be higher than if billed in a facility setting. And this is because in the facility setting, the hospital is also charging on the UB04 side and reimbursed on the APC value for the procedure. Now, professional fees, it's recommended, are priced at a multiple of the appropriate fee schedule according to the facility or non-facility place of service. Now we'll talk about some pricing transparency strategies. The first transparency strategy would be to develop a rational pricing methodology. So as we discussed throughout my portion of the presentation today, we want to ensure that patient prices are justifiable by setting them at either a multiple of Medicare cost or market comparative data. We also like to single out items that have negative patient satisfaction and find ways to price competitively against facilities such as outpatient labs and freestanding radiology centers. The second pricing strategy on this slide is to have share of cost estimators available online for patients. This strategy requires minimum employee intervention and is available on the facility website and provides basic pricing information of selected procedures. So this allows the patient to shop prices and avoid unexpected financial liability. This method is a way to publish prices and allow patients to have an idea of what they're getting into. And the final pricing transparency strategy is to create a patient financial obligation share of cost estimator. It's a mouthful, but the difference between this strategy and the one previous is that this strategy is a tool for hospital staff in that it empowers them to quickly and accurately determine the patient's financial obligation for a procedure by inputting the patient's insurance details and accessing the historical claims for the facility to develop a more true estimate of services. So with that, I think we need to move on to questions again. How did I do on time? Oh, I did okay.
You did good on time, and we already have some questions. They want you to define what you mean by rational pricing.
So rational pricing, it's basing it on something. It's not just picking a price out from the air. So we want to find a rational pricing methodology, again, based on a cost markup, a reimbursement multiplier, or some form of geographical data that's out there for us to rationally price those items against something. Peter, is there anything you want to add to that?
No, it's a tossed about term that is undefinable almost, but yeah, using Medicare fee schedules, Medicare reimbursement. One of the things that we maintain in our database is we know every price for every item for every hospital in the United States. So we do geographic market comparisons. We can take hospitals to the average, percentile. We can measure you against your internal cost accounting data or external data we are getting from First Data Bank or through your purchasing system. So just bringing all those data points together and updating Chargemasters, reconstituting claims, resettling those claims, and understanding the net revenue impact, or just that whole process of bringing it together is in our estimation a rational pricing process.
That sums it up well.
I hope.
Yeah. Right. I was looking, we don't have another question pending at this point. Well, we got one. I think Chris said one just popped up. So bear with us. We're getting to the question. What is your main or most recommended source of market pricing comparison, and how accurate is it?
Randy,
Peter,
I'll speak to that.
Okay. Yeah,
okay.
Do it.
Okay. We process about 140 million Medicare claims through our system every year. So we have, for every one of your hospitals, Steve, we have 10 years worth of their claims sitting on our servers in our data center in Austin, Texas. So we use that to mine data with. So we can find we can find a hospital that may have tiered pricing. They're charging lower on their outpatient ambulatory than they are in their ED or their inpatient pricing. So we take these 140 million claims and we parse them down so that we look at every code and every price and every patient type and every type of service, and we have those data points within our system. I was just going to say something. So what will happen is we can build up market groups based on any group of hospitals. We normally maintain for our clients 3 hospital groups. We have a geographic group, we may have an organizational group, and then we may have a specialty group, trauma hospitals, children's hospitals, cancer hospitals across the nation, that we can then map hospitals' prices to our peer prices, and then update the Chargemaster, update every charge transaction for the year for the hospital, and then take those updated charges through our contract models and determine net revenue impact. Randy, I think you said you just ordered the first quarter of 2018.
That's exactly right. That was what I was gonna add. Yes, we get it on a quarterly basis, and we just ordered Q1 2018, which should be here in the next month or so.
Okay, so we order this data from Medicare now on a quarterly basis. Our last quarter we have installed is the fourth quarter, calendar quarter 2017. That we have that both for inpatient and outpatient, Randy?
Yep, correct.
Okay, so inpatient and outpatient, we have fourth quarter of 2017 live in our system, and we have that data going back for 10 years, plus we have a 10-year history of every claim that your hospitals have generated. So I think we do a pretty good job on that. We also then interact with First Data Bank over on the drug side. We update the First Data Bank suggested wholesale price and wholesale acquisition cost prices on a weekly basis into our websites and into our processes for our clients. And we are in the process of developing a schedule of supply pricing using SKUs from our purchase item masters that we work with throughout our clients.
Great. Peter, we've got a follow-up question. Is there much variation in a given geography for commodity type treatment such as blood test, or is it pretty level?
It is all over the place, Steve. And whoever wants to ask that question, we can prepare for them what we call a market position summary, and we can show them where they are. But we can see an 80053, which is a comprehensive metabolic profile. I guarantee you, in your marketplace, I can find that at $350, and I can find it at $35 on an outpatient claim.
Okay.
She added on to that question.
Let's see. Is a follow-up, is that what you're saying, Chris?
Yeah, there's another one here.
Let's see.
You ready?
Yeah. How does a hospital justify the variation?
That's difficult. That's the dilemma we're in right now. That's difficult. I mean, you have a blood test that Medicare is paying you $14 on, and you're billing it at 15 times Medicare reimbursement. You're billing that thing out at $210, and you're being reimbursed $14. That's a very difficult position. That's exactly where we're at. That's the reason why you have these insurance plans now diverting patients from hospital outpatient over into independent testing. We do have clients that have tiered pricing, so they'll have lower prices on their ambulatory services for clinical lab, their big volume clin labs or their high volume radiology procedures, and then they'll have inpatient ED pricing at a different level to take advantage of some reimbursement terms they may have in their contract. But that's a very difficult question to answer, and there isn't any real answer to it. Absolutely.
Right. Chris, do we have other questions? I think at this point we don't have any pending questions, but I certainly want to thank both of you. Excellent presentation, excellent material. And, you know, Peter, I don't know if you or Randy would like any closing comments or any follow-up before we conclude.
Well, all I want to do is provide if you have any questions or you would like to see specific pieces of data that relate to your hospital, we can absolutely provide that to you and show you how your hospital relates to other hospitals in your peer group or however. So please just don't hesitate to call upon us, and we can provide you that at obviously no cost. So do not hesitate to call upon us.
Well, on behalf of the DFW Hospital Council and our member hospitals, we want to thank you. We really appreciate this presentation, and we really appreciate the time you gave us to continue the education, especially in revenue cycle management. So thank you very much.
All right, it's our pleasure. Thank you, Steve. All right, bye-bye.